Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video is missed by anybody.
Finally, we come on to the management of HIV positive women in pregnancy. So first we talk about the antenatal management, then we go ahead in the intrapartum management. So when an HIV positive patient comes to you, you confirm it, okay, and then you retest her again, okay, at around 52 weeks. And you, right from the beginning, you take a very thorough history about the partner, or about, from where did she finally contract the infection, if she's had previous pregnancy, what was the amount of care she took, what all ARVs she taking, okay, whether she's been compliant in taking that or not. And then, of course, you have to subject her to multiple testing, not just in confirming HIV, but knowing her current state of immunocompetence. So thorough history, physical examination, you go ahead to seeing the fundus, the neurological examination, the pelvic examination, skin, buccal mucosa, even the hair, the scalp, because here is where these opportunistic and fungal infections, they grow in and out. Okay, ask her about an appetite, ask her about the bowel habits, which are very, very important in AIDS patient. You get to know at which stage of infection she currently is. Is she in the incubation period or the window period? Obviously, she will not be positive in that case if she's in the asymptomatic infectious phase, or if she's in the proper infectious phase. Where exactly is she? And these number of tests, which are basic for everybody, should be performed. Apart from that, all those opportunistic infections should be screened for. These people can have, tuberculosis developing, gonorrhea, syphilis, chlamydia, CMV, toxo. All these can, find their chance and grow and multiply. So you should have a baseline, serology for all these tests. And up till now, I think at maximum I've included. I'm still left with SIF, gonorrhea, and chlamydia, which I'll be taking in the next class very soon. So these are the tests which you should baseline see, keep it with yourself to see whether, whether she's already immune or she can develop these infections further. Even if she's immune before the system is already going, is getting shut down. So you have to probably give a support system there also. Coming to the liver function test, what is a baseline liver function test, or renal function test, what medicines she is on, because they're going to affect either of these two systems. Of course, the specific tests, which I already have told you, the HIV viral load, that is HIV viral RNA, and the CD4 cell lymphocyte count. If it is falling to less than 200, she should be given a prophylaxis, especially against Pneumocystis jirovecii and other opportunistic infections. You have to counsel her regarding the risk of transmission to the fetus and to the serodiscordant couples. If suppose a male is not positive up till now, you have to give him a choice of barrier contraception. You can see, offering a medical termination of pregnancy has to be done only and only if the CD4 cell count has dropped to very low level for the mother to carry on the pregnancy safely. Okay, not because of any other thing, because we have seriously reduced the risk of HIV transmission vertically from 35% to 2%. That's a very, very encouraging figure. And definitely not a figure that should encourage anybody, the clinician or the couple, to abort the pregnancy. And of course, like I said before, regular, thorough follow-up, CD4 cell count again and again, intensive monitoring again and again, antiretroviral therapy to follow up properly, higher amount of folic acid, iron, calcium, vitamin supplements to support her, and antenatal visits have to be at least 4 registration visit, 2014 to 26 visit, 28-32 visit, and then finally towards the end. You have to screen for diabetes, okay, because protease inhibitors are seen to fluctuate the blood sugar levels. Consider hepatitis B, pneumococcal and influenza vaccines. So these shots have to be given. You know that pneumococcal influenza vaccines have to be encouraged by all female patients to take. Hepatitis B is another very important thing which you should ask her to take. And amniocentesis, CVS, all these, interventions, these should be discouraged, should be avoided as much as possible, and a multidisciplinary team should be involved to take care of this patient, not you alone. Now, the most important part, which is the antiretroviral therapy, or ARV or ART. Now, Quickly, tell me about what was option A, option B, and option B plus according to WHO and according to NAP. What was option A and what was option B? If anybody wants to speak, you can let me know. I'll just, you can unmute and you can speak as well. But I can also unmute you from here. So let me know if anybody wants to speak. Otherwise, you have your chat box. You can write down why did we shift from option A to option B or B plus. I will be explaining you B and B plus. But I want you to know why did we shift from option A to these options. What was actually option A? Now, since now most of you are there in the class, let me tell you or let me ask you how many of you read those two important snippets that I posted in the class in the channel last night. So I posted two very important messages in my Telegram channel last night. You must have seen it today or sometime. It was about the option A and why did we shift to option B and B plus? What was the problem? So I need to know this from my students. How many of you really know about option A, and why did we discontinue from option A, and why did we go to option B or B plus? So anybody who has, okay, only few are replying me back. Not everybody. Come on, guys. You've got to tell me what did you study? What is your opinion, or what did you understand out of option A, option B, and B plus? Okay, fine. You can still read. You can still, guys, go ahead and just look at the channel. It's got those two things which are very, very important for you to understand. Okay, all right. I'm getting some few interesting answers. Very good. See, that is what you get out of attending any class. There is your way of understanding the situation, and there is the actual way of the situation, right? So sometimes when you read in the book, you might not be able to decipher what is exactly what they're trying to say, right? So I'll tell you, you have your own viewpoint about it. Many of you are giving me the answers, but I'll tell you exactly what is the right answer. But I want some of you more to try. Okay? Keep trying, guys. I want you to know, I want to understand whether you do know what was option B and why was it discontinued. See, when we were reading, we had only option A. We didn't even know at that time it was the only option, or it was not by a term called option A. But over these years, we've seen some, practical problems in understanding or in, let's say, complying with the antiretroviral drugs, right? So fine, forget it. I'll give you the answer. Earlier on, when we were students, when we were being taught, there was a protocol to follow, and it was a very difficult protocol to follow because it depended on a lot of things. So when the patient, suppose a patient of HIV positive comes to you, and she comes to you, let's say at 10 weeks of gestation, and she says, "Doctor, I'm pregnant and I have HIV positive and I feel like continuing the pregnancy. Now tell me what I'm supposed to do." The way we would counsel her would be, well, you are at what stage of HIV, you want to see that, you want to know what is your CD4 cell count, and then till delivery you will have to take this, during labor you'll have to take this, after delivery you have to do this, and then we'll give this to the infant also. So there was different combination of drugs for different patients at different stages of pregnancy and labor, depending on the profile of the patient. So you see how many permutation and combinations it becomes. So to give the care to the patient and for the patient to accept it and remember it becomes very difficult. Okay? It becomes so difficult that, see, we as people living in the north, we see less of HIV positive cases as compared to probably the clinicians in south. So maybe they are in a habit of, writing down the prescription of the drugs. But for us, when an HIV patient comes, suddenly we have to see for so many things at what level of gestation she is, what is her CD4 cell count, what is her current immune status, and right now she's antenatal. So she has a different drug profile, different combination drug, different dose. Suddenly, when she'll go in labor, suddenly everything changes and her drugs change, her dosage changes, and then labor finishes in a couple of hours, and then suddenly again, postpartum, again new drugs come, new dosages come, and then so Even as a clinician, it is difficult for me to remember. So what do I expect of the female? She's not even, of this field. So NACO and WHO, they decided against this confusion that do not, and then antiretroviral therapy after some point in time, it will stop. And then again start when she gets pregnant again. That's also the thing. Okay. So NACO and WHO, they came up with a very simplified version of the same plan. Instead of confusing the clinician and the mother, a very simplified version of antiretroviral therapy came up, which was actually your plan B plus, to tell you. And a little change from B plus is B. Okay, I'll tell you in the slides to come. So what was it decided was that instead of going ahead for so much of testing and so much of permutation combination, let's keep it simple. Every pregnant patient, at whatever gestation age she comes with, whatever CD4 cell count she comes, she doesn't have to get the CD4 cell count every time she comes to you for the, in pregnancy. You do not have to completely monitor the CD4 cell count in order to change her ARV. CD4 cell count will be monitored, but for a separate reason, not to change her ARV dosages. So the dosages and the drugs will remain constant throughout pregnancy, throughout labor, throughout postpartum, in fact, throughout life, if she is maintaining good amount of CD4 cells. It's not dropping down, and her immune system is doing well with that. Continue the same ARV for the whole life, not only during pregnancy, labor, and postpartum. Okay, so that made things very easy for us and for the patient to remember, and the compliance improved drastically. That is the difference between option A and option B plus and B. We say B plus and B almost simultaneously together because there's hardly any difference. So the idea is, see, what we were doing earlier was to give, just to protect the mother and child vertical transmission, we gave more drugs. No, you have to give the similar number of drugs continuously throughout her life, be it pregnancy, be it labor, be it postpartum, and be it the next pregnancy. She's going to continue the same regime even in the next pregnancy until and unless it's otherwise indicated. Maybe in labor we give her a couple of extra drugs, but that ARV is going to continue. That was the idea that came from NACO and from WHO actually, and accepted by NACO. So there have been major changes in recommendations for ART from WHO 2013, accepted by NACO in 2014, have been shifted to option A to option B and B plus, which we're going to discuss later on. So it decided to opt for B plus lifelong ART, as especially why in Indian threshold is in Indian households is because there's prolonged breastfeeding in India. 25 to 30% female, they have second pregnancy planned. So that's the logic behind B plus by WHO to initiate and maintain ART lifelong, particularly in our setting. Epidemic setting with limited CD4 testing, we have that. Long duration of breastfeeding, we have that. High rate of fertility, again, we have that. Limited partners testing, again, we have that. And high partner discordancy rate, that we don't have so much. But yes, all the other factors are there in India. Hence, WHO and NACO had to accept it. Now, the difference between option B plus and option B. So, if you can see over here, we have option B. I'm sorry, we have option B plus, and then here we have option B. So, option B plus is very simple. Regardless of CD4 cell count, WHO clinical staging, you initiate and you maintain lifelong ART for all. Pregnant, non-pregnant, antenatal, intrapartum, postpartum, doesn't matter, for all. Particularly in generalized epidemic settings with CD4 cell count limited, testing limited, long duration of breastfeeding, and limited partner testing. As far as option B is concerned, so eligible mothers, the ART is required for mother's health. They initiate and maintain lifelong, or indications for ART is mother's health stage 1. If the CD4 cell count is less than 500 or irrespective of CD4 cell count, they can stop. They can stop 1 week after cessation of breastfeeding or immediately post delivery, if at all, to maintain this ERT is a little difficult in low resource setting if the mother is not comfortable, if the CD4 cell count is okay, or irrespective of CD4 cell counts, the option B gives a choice to stop the ARV. That's the difference between B plus and B. In option B plus, it is maintained lifelong. In option B, it is you can stop it under certain conditions, but that's not going to be asked mostly. People are going to be stressing more on B plus option. So if you cannot give option B plus for whatever reasons, then you go ahead for option B. This is what I wanted to tell you. Okay. So what do we give now? That's the next question. What is this ART we are talking about? You have few combinations. One is your highly active antiretroviral therapy, which you have studied like forever, in which you take usually 2 drugs from nucleoside analogs that are two are from non-nucleoside analogs. One is protease inhibitor. So you usually take one NRTI and one protease inhibitor. And now you have fusion inhibitors or integrase inhibitors. All these are also there. A word about efavirenz. Earlier on, it was category D drug. Now it is no more. After so many meta-analysis and studies, you now know that efavirenz is not category D drug. Okay. Now here, wake up, guys. I'm going to ask you one more question. Category A, B, C, and D drugs. Can you just quickly tell me what they are? Category A drug are what? Category B are what? And category C and D are what? Okay. Again, chat box, everybody, wake up. So some of you are typing, that's very nice. Some of you are trying to give me an answer. No, not from ART, just general. What is category A drug? Okay, I'll give you the first. Category A drug can be given easily in pregnancy. There is no inhibition to giving category A drug. What are category B drugs and what are category C drugs? What happened, Meghna, Suja? You're all not there in the class today? I'm getting no answer from you. I think Reshma is there who's answering. Good, Reshma, great. Yes, B are advantages overweigh or outweigh the risks. C is risks outweigh the advantages, but you can still give in dire conditions. You can still give category C drugs. D have to be avoided. And X, they are teratogenic, proven teratogenic drugs. Yes, right? So that's what it is all about. So efavirenz, earlier on it was category D, now it is not so. And here comes your antiretroviral drugs. This is how it is arranged. And even when I'm speaking or I bring these small pictures in my presentations, I try to restrict to the Indian scenario of drugs. So here you can see Emcure, Spegra. It has these drugs. I'll be talking about these drugs to you right now. I'm just showing you the chart. This is how it is managed. The highly active antiretroviral therapy, you take combination. So usually you take 2 NRTIs and one NNRTI or 2 NRTIs along with one PI or FI or II. And I'll tell you what they are. Okay? The next slide is going to say. So if you can see, you have over here dolutegravir, emtricitabine and tenofovir. Okay. So these are 3 drugs, and what they are, I'll tell you from the next slide. So you have these couple of antiretroviral drugs. Even here I have included an Emcure, pharmaceuticals drug over here, which has a couple of those agents which you can see over here. So these are fusion inhibitors, enfuvirtide and marivirog. Okay, they are. I'll tell you this also. They are category or B or C drugs. Mostly they are category B drugs. NRTIs like tenofovir used a lot. I think here we had tenofovir. Yes. So tenofovir is actually an RTI. One more NRTI which you'll hear about is emtricitabine. Okay, because these 2 are the newer generations, their side effect profile is far better than we used to use at our time zidovudine, adenosine, stavudine. Okay, now they are not used. Most of them have now been labeled as category C drugs. Some are category B still. But in tenofovir, emtricitabine, you'll hear these drugs pretty often. Okay, and then one of these PIs or IIs is integrase inhibitors, and this is protease inhibitors, right? So protease inhibitor ritonavir used. Here you have ritonavir only, okay. Then you have integrase inhibitors, dolutegravir. Over here we had this, dolutegravir, right? So this is integrase inhibitor and raltegravir. So you should know at least 3 names, in which you have only 2, you know 2. At least these NRTIs, you should at least know 3 names. Tenofovir, emtricitabine, because they use so much. And you take 2 NRTIs always, so you should at least know 3 to 4 names from NRTIs, and 2 names each of protease inhibitors, integrase inhibitors, and your fusion inhibitors. Now the triple therapy. If possible, it should be the treatment of choice and should be started as soon as possible and should be continued throughout the pregnancy, labor, and postpartum period. And side effects are many: myopathy, neuropathy, lactic acidosis, pancreatitis, hepatitis. So you have a lot of GI discomfort with this ART drugs. Then there was another therapy called as nevirapine therapy, but it's pretty expensive. It was recommended earlier on, not now so much. Now mostly option B and B plus are used, in which they recommend for us to use either the triple therapy or at least the therapy of 2 NRTIs with 1 PI, FI, or II. So what was the need for shift from option A to B plus and B? I think I've extensively spoken about it. There is no need to further elaborate it. So we're going on to the next slide. Now we talk about a very dynamic phase of labor, and we've studied it enough to know that 40 to 80% chance of transmission to the baby occurs in labor. So my question here to you all is, if suppose a patient comes to you who's got, let's say CD4 cell count is somewhere around 650 copies per microliter. She's very, properly taking her ARVs. Pretty compliant patient. She's been coming to you again and again, but she's highly anxious about labor because she's read a lot about transmission of virus to the baby, vertical transmission, multiplying during labor. And now she's asking you a question, saying that, doctor, how can you help me during labor so that my baby is least affected, if at all? Would you give her a choice of elective cesarean section, yes or no, based on what recommendations? Let me hear it from my dear students. You can answer, guys. Please answer whatever you feel like. Whatever you feel like. It doesn't matter. You're right. You're wrong. You can just answer. See. Okay. One is no. One is yes. Good. Good. I need more students into yes and no's will be fine. Will do. No problem. I do not expect you to tell me the guidelines right now. That's my job. I'll do that. You tell me. Suppose a question is this, a leading question by the patient who's your antenatal patient, that doctor, I don't want my baby to be the least affected. Please save my baby from this vertical transmission. And from all I know is that labor is the most important time when she's going to get the infection. So please save me. If needed, I am ready for cesarean section. Would you go ahead for an elective cesarean section for this patient and avoid labor altogether? Yes or no? Come on, guys. You can always answer. You can always answer whatever you feel like. Okay. So some are no, some are yes. Right. So I'll try to give you the answer for this. With recommendations or with guidelines. Okay. Depending upon immune status. So, you know what? RCOG usually does not ever say for cesarean sections, mostly. ACOG is pretty liberal in this, so I was not surprised. But RCOG 2010, that recommends elective cesarean delivery at 38 weeks for HIV positive mothers taking the ART regimen. So you know that she's been taking that. The intelligent thing about this part is, dear, that no matter how much ART you've already taken, labor predisposes the risk to many folds or many multiples during labor because of so many dynamic changes. See, maternal secretions are anyways going to touch the baby during the passage through the birth canal. It's not just in the blood, it's actually through the birth canal that, like something like a GBS, remember? It was specifically told at time and again was referring to the fact that it's the vaginal secretions that, will give the baby the infection. It's almost the same line. It's the same lines. You somehow restricted the transmission during pregnancy, which in otherwise also is not so much. It's just 20%. They have 50% to 70% during labor and almost 30 to 40% during breastfeeding. That is what you have to curb, guys. So RCOG and even ACOG recommend elective cesarean section. ACOG says with a viral load of more than 1,000 copies. But RCOG says, even for a patient who's compliant with HART, go ahead, do it. Okay? So elective cesarean delivery can decrease the risk of vertical transmission by half. Half. Can you imagine? That's a big number. Big number. All right? And which is forming the basis of these two important guidelines. But after a while, you'll see what NACO has to say, what WHO has to say, which is why we in India do not follow. So the morbidity of cesarean sections is 5 to 7 times as that of vaginal delivery. Everybody knows. Patients, let's say movement or ambulation or hospital stay are all increased in cesarean section. You've cut the abdomen, and in normal delivery, it's nothing like that. There is more bleeding in cesarean section. There's less bleeding in normal delivery. So the morbidity increases, but the vertical transmission decreases. What's more important to you? That's the question. And a setting like India, we call it a low resource setting. We depend more on normal vaginal deliveries. In fact, till date, 70% people are dependent on normal vaginal deliveries, no matter what, right? Now, let's see what WHO and NACO has to say. So WHO, NACO recommends cesarean delivery only for obstetrical indication, like we hear in so many guidelines. But if at all you have to do cesarean section, you go ahead and give ARV prophylaxis, you go ahead and do early cord clamping, avoid rupture of membranes, use blunt needles so that inadvertently you don't get pricked, peripartum antibiotics, universal precautions to be followed, like you do in hepatitis B cases or, of course, if you've operated upon HIV individuals. And if you are planning for a normal labor for a patient of HIV, how you have to be careful. No PV again and again, no artificial rupture of membranes, no use of fetal electrode for fetal blood sampling or whatever. They should best be avoided. Of course, you have to go and see the viral load and CD4 cell count, and you have to be prepared with the ART, especially during labor, to save the vertical transmission. She is on ARV, but you are giving a little bolus doses in labor, which I said before also. Zidovudine has a loading dose of 2 mg per kg per hour by IV infusion, may be given 4 hours before the cesarean section or at the onset for vaginal delivery, followed by a maintenance dose of 1 mg per kg per hour until the cord is clamped. So you give a loading dose and you give them a maintenance dose per hour, 1 mg per kg per hour. Obstetrician, pediatrician, staff attending the women have to have those universal precautions, gloves, goggles, mask and everything. Operating floor should be cleaned with 0.5% sodium hypochlorite. Avoid the needle stick injuries. Disposable syringes and needles should be used, which they are disposed in puncture-proof containers. Healthcare workers attending these women should avoid contact with any spillage of the blood or of any other secretions. And suppose they got exposed, then there is something called as post-exposure prophylaxis. What do we do in that? All labor rooms should have a clear policy on this. And what do you do that? It should be written down. What immediately should you do? Zidovudine 200 mg thrice daily, lamivudine 150 mg twice daily, nelfinavir 750 mg thrice daily should be continued for 1 month, 4 weeks, 1 month, and that reduces the risk of seroconversion by more than 80%. So you'll be in the safe zone. And now just a couple of, quickly we want to just see NRTIs, some drugs are B category, category C. So just look at the B category because we use them more. So tenofovir, like I said, used a lot, didanosine, and now Emtricitabine. We used to use this zidovudine, lamivudine. They were highly efficacious. They still are, but they're category C drugs. So you can still use them in, the third trimester, no problem. Then protease inhibitors, you have many who are B over here: ritonavir, sikanavir, nelfinavir, and alazanavir. Okay, and then you have NNRTIs, which again you have many Bs over here. You have nevirapine over here, which is given a lot. And then you have entry inhibitors, in which you have most of them. We just spoke about this enfuvatide and maraviro. They are both category B drugs, but in integrase inhibitors, they are category C, raltegravir and elbitravir. Okay, so this is just to show, nothing to memorize from here. And now the last few slides of my presentation. You have the care of the neonate. The moment the neonate is born, immediately go ahead and wash away the blood from the newborn. Okay, should be bathed immediately, but avoid this nasogastric suctioning. Please avoid denuding the mucosa or eroding the mucosa with whatever brisk attempts you do to kind of clean the suctioning or cleaning the airway. Avoid doing that, but bathing immediately, cleaning immediately. Breastfeeding was contraindicated in the past to decrease the MTCT of virus, but according to WHO, decision about breastfeeding should be made by national health authorities and individual mothers after telling them the risk. Our national guidelines on feeding, they say exclusive breastfeeding for 6 months, continue feeding till 12 months if possible. Do not worry, we'll help you with the ARV, as it is the difficult period is gone. When the 80% chance of transmission was there in labor, you went ahead and did the labor or went ahead and did the normal vaginal delivery. Now when only 30% risk of transmission is there, you are avoiding the breastfeeding. That's the best thing that you can do to your child, to give your own breast milk. It's going to be pumped up with so many antibodies which the child badly needs right now. Okay, so only when breastfeeding cannot be done or mother's choice, then you can go ahead and give a replacement feed. So now comes the antiretroviral therapy to the neonate. Okay, what do we give? Nevirapine. We give nevirapine in the dose of 2 milligram per kg from birth for 6 weeks if it's breastfeeding, or 4 to 6 weeks if it's not breastfeeding. Okay, we can alternatively give zidovudine syrup, dose of 4 milligram per kg, given to the baby twice daily for first to 4 to 6 weeks of life. Early infant testing, you do DNA PCR at 6 weeks and 6 months. And if positive, you confirm with whole blood. You confirm it again. You start the ART, in infants as well. And coming to postpartum care, well, you have to be very sure that she's adhering to the ART. It's not that she's finished off with the pregnancy, now she stops taking that. For her own health also, she needs the ART. There should be no mixed feeding. Now, important thing about mixed feeding is that it's seen to cause this upset mucosa. It denudes the mucosa, and there is more chance of viral transmission into the bloodstream because the mucosa doesn't function properly. It gets denuded because of these mixed feeds. Cracked nipples have to be treated, very important. Mastitis has to be treated, depression has to be treated, continue antibiotic prophylaxis, and contraception I'll just take up in the next slide, which is going to be my last slide. Now, HIV positive women, they are strongly advised to use dual contraception or double Dutch, we call it. It involves a barrier method to reduce the risk of sexual transmission, and then maybe one more effective contraceptive method like maybe OCPs or the POPs, or just maybe an implant or injection. IUCD is category 2 for HIV and category 3 for full-blown AIDS. AIDS means you're talking about now she's in the symptomatic period. And the spermicides is best treated. So this was about the HIV in pregnancy, guys. I hope you got the message very loud and clear, what to give importance to and what to just brush through. Okay, so things like pathogenesis and diagram of HIV, they cannot be left behind, but you should just read them minimally. You've already studied probably very well in your undergraduate class to be able to write a good answer, and I'm sure you'll do very well in your, let's say, pathogenesis or regiopathology. The focus of attention will always be diagnosis and management for most of the diseases. So now, since we've already through with viral diseases, now the disease will be focusing so much on, the dosages of the drugs, the different kinds of drugs, the combination drugs that you have to remember. So guys, I finished my class today, and taking up TB will not be right. So what I'll do is I'll just post its PPT in the Telegram channel. You can just see the PPT for yourself. And TB is not a very big topic. Most of it you already know. You know about the antitubercular drugs. You know about its dosages. You know about the diagnosis of TB. You know its effect on pregnancy. And I've already marked the recommendations and everything in the slide. So, and again, it will stay over for some time, it will be removed after some time. So please make sure that either you watch it tonight or latest by tomorrow, so that you're done with these two important topics. And I'll come up with the next topic, which is going to be the sexually transmitted diseases, syphilis, chlamydia, and gonorrhea in my next class. If you've got any questions now, I am open to the questions, so you can ask me, guys. And for all others, if you want to leave the class, you're most welcome to. Thank you so much for staying with me for this class, guys. It's you who make this class wonderful, and not me alone speaking in front of the laptop. Believe me, sitting over here, I usually just feel like I'm speaking to the laptop, but it's really fun when you people start answering the questions. So thank you so much for being, such excellent students, but I would want a little more interaction in the class. So yeah, if you've got any questions, I'm open to that. Otherwise, like I always say, you can ask me these questions personally on my WhatsApp account, or even in the channel with one another. It's always a treat to see everybody helping each other. So that's great. Okay, guys. So I can wait for 4-5 minutes, and then we can close the session. Yeah, one more very important thing that some of you have got are giving me a request for a couple of classes. Yes, your requests are very, very important to me, guys. Very important to me. But currently, I'm on a schedule. I'm currently taking up only infections in pregnancy. After this, I'm going to decide the next schedule of my classes. And if your request falls in that, I'm sure I'll be taking up that. Definitely, there's no point that I will not. Many of you wanted contraception, and probably I'm thinking very seriously on taking contraception. If there are any other advices for the class, please be my guest. You can tell me on my personal WhatsApp account or personal Telegram account. I think WhatsApp is always better because Telegram doesn't usually give a lot of notifications, but WhatsApp is. So you can just reach me there, and we can take it up from there. So guys, I'll just stop the recording, because in that case,